So good afternoon, everybody. My name is Kelly Diak, and I am very excited to be able to present to you this afternoon. To give you a little bit of background on myself, I have spent my entire career in the laboratory, having been in the field for almost 29 years as a cytotechnologist, with my specialty in cytotechnology to start, and later achieving my certification in histology. I worked in histology and cytology on the bench for about 10 years, transitioning to the AP supervisor during that time, and then for the last almost 19 have overseen the Anatomic Pathology Departments as the technical advisor. I have experience with single site departments as well as managing a system AP department with a core lab and satellite locations feeding into that central location. In those 29 years, I have been involved in about 30 inspections, both as an inspector and as an inspectee, if you will. During this time, I have learned many lessons and developed a keen sense of what is expected during an inspection and how to prepare for one. It is this experience I would like to share with you today to hopefully make your inspection a tad bit easier. And just another kind of sidebar comment, more recently, I have learned that my inspection experience will be expanded a little bit more to include the virtual inspections that CAP has been talking about for some time during the COVID pandemic. So within the next few months, I will have my first opportunity to do a 100% virtual inspection of a system. So I'm very excited to add that. So with that in mind, the agenda for the presentation this afternoon will include the following items, excuse me, in relation to CAP inspections of the Anatomic Pathology Laboratory. We will first talk about how inspections play a role as a key component within a quality improvement program. We will discuss ongoing methods of preparing for CAP inspection. We will talk about activities that should be performed on time for inspection day. Our discussion will then take a turn towards inspection organization, and then finally we will touch upon several checklist hot topics and ways to address them. So a key component of any quality improvement program are those external assessments. Inspections are a required method of external assessment. Laboratories must complete external assessments as part of their ongoing quality improvement program. Inspections fulfill this requirement. Inspections are performed by regulatory and accreditation organizations for purposes of obtaining and maintaining the laboratory's license or accreditation. One of the ways this is accomplished is by participating in a program offered by an organization that has been approved by CMS to provide what is called deemed status. Deemed status means that the organization has a CMS-approved plan to evaluate a facility's CLIA compliance. These organizations must evaluate a lab based on CLIA regulations at a minimum, with additional standards often being added by the regulatory agency. Examples of such organizations are CAP, COLA, and Joint Commission, of which most of you are all very familiar. Today we are going to talk about CAP inspections specifically. However, much of what I will discuss can certainly be applied to other regulatory bodies. So generally speaking, all regulatory agencies who have achieved deemed status have a list of standards that are given to facilities to set the expectation of the requirements that must be met in order to achieve accreditation by the organization. CAP has a massive library of standards, of which many of you are probably very familiar. Standards are all defined with a phase 2 being more critical than a phase 1. CAP takes a peer review approach for inspections, meaning that facilities are inspected by a group of laboratorians from a similar sized and type of facility. Inspections from CAP can take a site or system approach, depending on the kind of institution and preference of the leadership team. Site inspections are just as they sound. They are one site inspected usually on a single day by a group of inspectors, Whereas system inspections, on the other hand, are a group of facilities that comprise a CAP-defined system that are inspected over the course of several days by a group of inspectors, and with this group generally being accompanied by a system CAP inspector. Deficiencies are cited as necessary, with corrective action being required for submission to CAP for each Phase 2 deficiency. The facility I work with started out as having site inspections, and then we moved to the system method about 10 years ago. So our inspections currently last probably about 4 to 5 days, with our 11 facilities being inspected over the course of that time period. So I've found over the years that it is most effective to take an ongoing CAP readiness approach to the external assessment component of the quality improvement program. By that I mean that labs should not approach inspection as a one-time annual activity. This makes for an extremely stressful time for either the interim inspection while completing that required documentation that needs to be submitted to CAP, or as the on-site inspection window draws near. Instead, I would suggest an ongoing approach to inspections, which is really the spirit of the intent of external assessments. As leaders, it is our responsibility to make sure our labs are always compliant with the regulatory standards, not just once a year during the inspection window or at the time of the interim. From a practical standpoint, it also makes a lot of sense. Accredited labs have a lot of expectations set before them. Spreading the work to accomplish this is better managed over time. Every year around the summer months, CAP publishes their newest version of the checklist. They are available on the website. Additionally, they publish some nice documents that assist with the ongoing assessment of the checklist version. There is a changes only document that calls out all the standards that were added, deleted, and revised. There are also custom documents that allow a facility to pull their checklist based on the lab activity menu they have on file with CAP for a particular department. This pares down that master checklist, which includes every single standard available, some of which may or may not be applicable to your facility. Annual activities should include a formal audit of the new versions of the checklist as they are published. At my facility, each supervisor has an audit assigned to them, which includes a review of any checklist as it applies to their department or departments. They are required then to review the newest version and make any necessary changes in the department. Annual audit activities should not only include reacting to the changes made in the requirements, but it is also a good time to review the entire checklist and your departmental compliance. Depending on the timing of your interim, this can be done at the same time. What you are trying to avoid with the principle of ongoing checklist audits is a massive assessment only at the time of inspection, which would have to include all checklists that have been published since the last inspection you had. This is just not a good process because it means you were non-compliant when the newer edited standard was published and really doesn't give you that opportunity that you need to appropriately change or implement new processes. As checklist audits are performed, it is also a good time to review all policies, procedures, and forms, making any revisions and creating new as necessary. Additionally, implementing new or revised work processes is easier and more effective because you have the time before inspection to not only create or edit the accompanying policy or procedure, but you also have time to educate your staff, which is a required part of either implementing new processes or changing processes. You must show that that education has taken place. One of the biggest pitfalls of waiting until right before inspection to verify compliance is that if there are changes that need to be made, there is often not enough time to fully execute the changed or new process. Just writing up a policy to reiterate the standard does not fully meet the expectation. While inspection teams might have their own list of examples they would like to see, Having your evidence of compliance ready at the time of your inspection lends to a smoother and more effective inspection. This eliminates the need to rush around trying to find an example of something when there is such a limited amount of time and so many things to do during an inspection. Knowing what evidence of compliance is needed is important, as some activities do not happen every day. Maintaining a list of what evidence of compliance is needed and then sharing with the leadership team so that they know what they need to look for is good practice. Examples should cover the time from your last inspection to the current inspection. Inspectors want to see that you are meeting the standards all the time, not just that month prior to the inspection window. Examples should also not represent time prior to your last on-site inspection. Generally, these are just too old, and unless it's something that only happens, once a year or once every 2 years, it's really not going to be relevant to your current on-site inspection. So as we get closer to the inspection window, there are some activities that are most helpful when performed on time. And by that, I mean no more than a month or two before the inspection window actually opens. The first activity is a document control audit. I will do a walkthrough of the department, and honestly, I do this on a regular basis. And I look for things like policies posted on bulletin boards or walls, taped to walls, post-it notes, cheat sheets, and then I look at the forms that are being utilized throughout the department. Generally speaking, when I find documents of this type, in particular to the posted policies and any cheat sheets, I will ask the leadership team to remove them and discard. The reason I do this is that these sorts of employee-created tools often lead staff to do things that are not in line with the documented policy, or it appears as if they do. As I perform a cursory review of forms the department is utilizing, I will do a check of the document control to ensure that they are using the correct version. Our document control system is electronic, so I am frequently encouraging the teams to eliminate files where they like to keep copies of forms and ask that they print the needed form from our document management system instead. So sort of as they need that document, they're asked to print it so that we don't end up with a whole bunch of documents out there that aren't current because they didn't realize that the newer version, or that there is a newer version. If you don't have an electronic method for document control, that's okay. Staff still just should be reminded to follow whatever process you have in place to ensure the use of the most current document. Whether that process is manual or electronic, the requirement is still there. And so staff need to make sure that they always know how to locate that most current form and that that is what they're utilizing. Deficiencies are easily cited when documents, including policies, procedures, and forms, are not well controlled. A month or two before our inspection window opens, our leadership team will complete a review of all evidence of compliance to assure we have accounted for everything. Again, this does not eliminate the possibility that the inspection team might ask for additional examples or have items of their own that they would like pulled. They absolutely have the right to do that, but it is very helpful in eliminating anxiety and knowing what you need for the inspection. At the very least, it is a resource to remind you what it is you might be looking for in the event the inspector asks for a different kind of the same example. Another activity I will perform about 2 weeks prior to our inspection is an audit of the materials in the department. We perform quarterly audits as a general rule. However, I like to go through everything just to make sure there were no oversights. By materials on the slide, I'm referring to reagents, consumables, bulk liquids, waste, general supplies, etc. It is also helpful to do a general review of all instruments, including the stainers and the processors, to make sure all reagent containers are appropriately labeled with the contents. Assess all processor retorts, stainer stations, waste carboys, and any bulk liquids like alcohols and xylenes. There should be no container filled with any sort of contents that is unlabeled. When checking your materials, make sure that the label is appropriate and contains all required elements. You should have a date changed, filtered, and expiration date where appropriate on all reagents. Again, this includes all IHC antibodies and reagents, special stain reagents, and processor reagents, and includes not only those primary containers, but the secondary containers as well. We'll talk a little bit more about this in the following slide. And make sure you dispose of anything that is expired. This leads to a very frequently cited deficiency. As a point of review, all reagents must be labeled with the following components: content and quantity, and then also concentration or titer if applicable, any storage requirements, the date it was prepared, filtered, or reconstituted by the laboratory, an expiration date, and then those safety precautions. An open date only needs to be indicated on the container if it changes the expiration date for the contents. Secondary containers should be investigated very carefully because oftentimes this is when deficiencies are noted. Anytime reagents are placed into a secondary container, the container must be labeled appropriately. For example, if you are reconstituting a reagent or if you are putting alcohols into a larger dispenser, you lose that labeling that comes with the primary container. So when you move these reagents to a secondary container, you need to label that secondary container as if it were the primary, essentially. So the contents of the secondary container must be clearly labeled along with the expiration date and safety precautions and storage requirements. While mock inspections definitely require a time commitment, they are so very beneficial. It is most helpful if the mock inspection is performed by someone who is familiar with the checklist for the department, but does not necessarily work in the department being inspected. This is to eliminate the bias you might see from staff who are in the department every day, and to have an expert evaluate compliance from another viewpoint. This activity can be as in-depth as you want it to be. If you don't have time to go through the entire checklist, even doing a random sample of the requirements is helpful. Sometimes this can just focus on sort of those like heavy hitters as far as deficiencies that are frequently seen, or you can look at deficiencies that have occurred in the past in that department, whether it's histology or cytology. These are just effective whether they're performed announced, so the supervisor knows when the mock will be performed, or if they're unannounced, so just where we just show up one day. A lot of times we will do this announced simply for scheduling purposes, but either way, it works. When I perform the mock inspections, I will generally take both the histology and the cytology checklist with me and just kind of pretend to be an inspector. I'll go through drawers, cabinets, refrigerators, freezers, flammable cabinets, etc. I interview the staff as much as I can. This serves sort of a dual purpose in playing a role to assess department readiness, but is also helpful for your newer staff that might not be as familiar with the inspection process. It effectively assists in making them feel more comfortable when the actual inspection time rolls around. Upon completion of the mock inspection, I will prepare a report for the supervisor, generally outlining what I would have cited as a deficiency if I was performing a real inspector. And then as follow-up, I will request from the supervisor a response and then sort of corrective action, but obviously the corrective action is something that they will put in place prior to our on-site inspection actually occurring. In addition to the mock inspections, to help your team feel comfortable with the process, general coaching is also beneficial. We are getting away from the inspection teams that used to come in and talk to the leader only. Now inspection teams are coming in and interviewing the bench staff. They know the leaders know what is supposed to be happening. They want to know if the staff know. Share the checklists and the evidence of compliance with all staff. Make sure they spend time reviewing both the evidence of compliance and the checklists prior to inspection so that they're aware of the things that the inspectors will be looking for. Ask your staff to talk through their daily tasks. For example, ask them to walk you through their process when they receive a specimen in the gross room. What steps do they take after it is delivered? Inquire if they know how to find an alcohol or formalin safety data sheet in the event of a spill. Do they know where the eye wash is? Should they splash it in their eyes? Are they familiar with the evacuation plan? Do they know where to go? Do they know where to find it? Can they demonstrate how to find a policy or procedure of their choice? Kind of related to the last two bullets, there's been many times where we've had inspectors come in and just ask our staff to produce a safety data sheet or show me any policy. And sometimes they really struggle to do that. And not so much because they don't know where they're at, but because they're just nervous. So practicing with them is very important. Ask a specific question about a policy or procedure. For example, tell me what steps you would take if you receive a specimen from surgery and the container is labeled right fallopian tube and the requisition states left fallopian tube. Make sure that this process matches what is stated in the policy and procedure. Ask if they know what the compliance is for their frozen section turnaround time, for example. Perhaps ask what other quality monitors they're aware of that are being tracked and recorded for the department. Can they speak to them or can they give you an example? Coaching your team helps them to understand what is going to happen during an inspection. And it also gives them ideas of areas that they might need to refresh themselves on prior to inspection. I do always tell my team that they just need to talk about what they do and that there is nothing wrong with saying, I know that this procedure gives me information on that. Let me pull that up so I can tell you what I would do next. I firmly believe that being organized for an inspection is half the battle at making sure it goes smoothly. The more awareness there is of the expectations and the more prepared you are for the inspection, the smoother it will go. This does not, of course, offset the importance of compliance, but it leads to a more effective peer review. Preparing case material ahead of time has always been a constructive method of organizing myself for an upcoming inspection. An inspection team might also ask for their own list of cases and slides. However, I have always found it beneficial to have cases and their corresponding reports pulled ahead of time, both for histology and cytology. Generally, I will pull the slides and put them in a folder and then generate the report and place that with the case. It is most helpful to have a wide variety of cases covering many of the requirements stated in the checklist. The next slide will outline some of the case types I generally have set aside. So here are some suggestions based on standards within the checklist of cases that could be pulled. And you'll kind of see as I go through this list, a lot of the cases that are on here sort of serve dual purposes. They could be utilized for the case or slide review, but are also used to demonstrate other like report examples. So not necessarily just case or slide examples, but also the case or report example when they're looking at certain standards within the checklist. So for example, like an intradepartmental consultation is an example of that. So for surgical pathology, I would pull a case that has a well-developed synoptic report or cancer protocol. Cases that have predictive markers, including the ASCO CAP scoring, are helpful to have available for inspectors. Additionally, I try and find several good cases where there is a complex gross description with those block designations and then the processing information, such as with a breast resection. Several cases with frozen sections and an example demonstrating reconciliation between a disparate IOC and a final diagnosis kind of rounds out that list. For cytology, again, I will pull a variety of both GYN and non-GYN slides, looking for cases with medical cytology fluid descriptions, a pap smear that was signed out by one of my cytotechs, one that was QC'd by a cytotech, and then one that went to a pathologist for pro review and kind of demonstrates that sign out. Various pap smear cases should be pulled encompassing the whole paradigm of GYN diagnoses, so your unsats, a negative, an ascus, a low sil, and a high sil, and any malignancies should you have them. For both cytology and surgical pathology, cases with the following items are good examples to pull. If you have addendum or supplemental reports, whichever you call them. Anything with special stains. So generally I will try to pull a couple of cytology cases with special stains and then surgical path with special stains. Same thing for IHC. I'll try to do a little bit of both. Revised or corrected reports. Anything with an intradepartmental or an extra departmental consultation. Again, these are kind of where you get into that sort of dual role where I've got the case that I can show, and then I also have sort of my example of an intradepartmental consultation report that can also be reviewed. Cases where there was documentation of provider communication of significant or unexpected findings are always good to have on hand. Correlation of those special studies, so your flow, fish, again, IHC, special stains, etc. And then examples of the performed at statements, cases with that. So that applies to all of the cases at my facility. So we generally have them based on where the technical pieces were performed, and then based on where the sign out location, if that occurred at different locations. So usually I have about 15 to 20 cytology cases ready and about 20 to 25 surgical pathology cases available. If you do autopsy, pull a couple of those with a completed PAD and FAD, and then make sure to pull both fetus and adult if you perform both of those at your facility. So a great first impression is to make sure your department is clean. My stance on this is a well-organized and clean department goes a long way to demonstrate your attention to detail and importance of making sure you are representing a well-run department. Ensure the floors are clean of paraffin, or as much as possible, and supplies are put away. Declutter your counters and make sure your instrumentation and equipment is clean. Empty those garbage cans, replace sharps containers as that kind of final check to ensure your department is represented well from the time the inspectors walk through the door. I always tell my staff a great way to declutter your department is to make sure you are following your retention policy. So keep what you need to, and that's it. Keeping things longer than you need to is just as much of an issue as not retaining items for the correct length of time. Reviewing your retention policy should be an ongoing process, obviously, but double checking this before inspection is an effective organizational tool. So years ago, I was introduced to the concept of an inspection binder. While at the time, it seemed like a whole lot of unnecessary work, I grew accustomed to the idea and now completely endorse the concept because I have seen many times where it has been invaluable. I have since developed an electronic version of this for my departments, but the concept is still the same. The inspection binder, if you will, is a copy of the histology and cytology checklist, one in its own binder, with each standard occupying its own page. And then behind each standard, I place all evidence of compliance, including the appropriate policies and procedures and/or examples. As I mentioned earlier, I have completely converted this to an electronic format, so it is pretty easy to manage, but either way it serves the same purpose, whether it's electronic or whether you don't have an electronic means of doing this, and so you do it actually in a binder. This resource does a few things. It keeps me honest and forces me to take action for each standard and ensure I am compliant. It provides a resource for both myself and my staff the day of inspection in terms of keeping me organized. Inspection day always consists of what seems like me running around in a million different directions, so this resource kind of grounds me when I am asked a question and my brain is just not quite remembering. And then finally, this provides a resource for my staff should I be sick or pulled away the day of inspection. In all ways, this concept has proven over and over again well worth the time it takes to put together. So the last section of items we're going to discuss today is going to include hot topics as related to the Histology and Cytology departments. These are items that either I have seen while inspecting or have struggled with while being inspected myself. So training and competency is the first topic we will discuss. Documentation for both training and competency should be available for every employee. This is particularly true for staff that are considered high complexity testing personnel, including non-pathologists that perform gross tissue examinations, cytotechnologists, and then any staff who evaluate imaging systems. High complexity testing personnel should have training documentation as well as competency that fulfills all 6 elements of competency as defined by CLIA. This competency must be performed at 6 months and 1 year during that first year of employment and then annually thereafter. While histotechs, your prep techs, any assistants are not considered high complexity testing personnel, and they're not required to abide by those same competency standards as those that are, you should still be able to demonstrate competency for all lab staff as well as evidence of training. Any staff holding CLIA roles then for those high complexity tests must also have documented competency for that CLIA role. So by that, I'm speaking of your general and your technical supervisors. Finally, pathologists are required to have some level of professional competency documented. Educational documentation should be retained for all high complexity testing personnel. This would include, again, your pathology assistants, cytotechnologists, and personnel who evaluate your imaging system data. Additionally, those staff that hold CLIA roles for high complexity testing must also have documents available proving their educational background meets the requirements of the said CLIA role. This includes, again, your pathologists that retain the clinical consultant, technical supervisor, and medical director roles. Educational documents can be tricky sometimes. The documents provided must have all essential elements. It is a requirement to have the field of study listed on the document that is retained for educational documentation compliance. This is the only way to confirm CLIA requirements for education are met. If the diploma is what has been submitted for educational documentation and it does not have the field of study listed, then you must obtain the transcript. For example, if your PA has a diploma that states Bachelor of Science or Associate of Science, and that's it, it's not good enough. You need to have a document that tells you what that science actually was. So again, for example, the transcript would indicate Associates of Science or Bachelor of Science, and then it should say on there somewhere that that field of study or major or concentration or something was biology, for example. For a cytotech, it is acceptable to only have the ASCP certification to demonstrate educational requirements. This is one of the only, if not the only, role in the lab where this is acceptable. A certification card is not acceptable for CLIA roles or other roles in the lab. It must be a diploma or a transcript. For staff that are not designated as testing personnel, the only educational documentation really necessary is what's dictated by your facility or the job description. Test method validation documentation must be on hand. This includes documentation that new predictive and non-predictive antibodies that were implemented have had a validation completed prior to going live. It also includes lot-to-lot comparisons for IHC antibodies and their detection systems. If you perform ISH, new probes must similarly have validations performed as well as lot-to-lot comparisons. Validation documentation must be present if you made changes in processing protocols, including decalcification changes. And finally, thin layer cytology methods must also have validation performed upon implementation. Generally speaking, items are reviewed if implementation occurred within the 2 years since you were last inspected. So usually there isn't a need to produce documentation prior to the last inspection because the assumption is made that that has already been reviewed. The only exception I have seen to this is when there's actual technical issues that are identified during the inspection, and for some reason the inspectors want to go back and look at that documentation. But generally we don't have that out and available. The next topic I want to highlight is screening compliance as related to cytology. Screening compliance is important for the cytotechnology team to ensure that they are abiding by the governmental regulations in terms of workload and screening maximums. It is critical to show that workload is being recorded and reported on a monthly basis and that screening limits are set and adjusted when necessary. Cytotech discrepancies should be noted with any corrective action documented as necessary. And then finally, while we don't see it a whole lot, and we don't do it at our facility, anytime you have that the pathologist do any primary screening, that workload must also be recorded following that same process as your cytotechs do. Quality monitoring is very important, as we all know, for every department and will always be a topic of discussion during inspection. All departments are required to have monitors established, and histology and cytology is absolutely no exception. Not only should quality monitors be demonstrated, but more importantly, corrective action must be shown when monitors fall below threshold. Quality monitors can be such that they are ones suggested in the histology or cytology checklist, such as turnaround time for frozens or the final diagnosis and IOC correlation. But there should also be monitoring performed for those high volume, high risk, and problem prone areas. The monitoring, we need to make sure covers all phases of testing. So that would be anything pre-analytic, analytic, and post-analytic. And then data should be trended over time and available to the staff. So the bottom line question really that you need to be prepared to answer is, what are you doing in the department to ensure that you are providing good care? And what are you doing to improve the services provided? As mentioned in the previous slide, the more important step of quality monitoring is ensuring that you are putting corrective action into place when the compliance falls below threshold. You must do something about data that is gathered and either shows a failure by the employee or by the process. Inspectors will look for this data guaranteed. The corrective action or actions taken is just as, if not more important, than collecting data itself. Collecting a bunch of data with no outcome has no purpose and is not reflective of an effective quality improvement program. And I will say, generally, I see more and more focus on the corrective action during an inspection than I have in the past to a great extent. So one of the most frequent issues that I encounter during inspections is document correction. Lab staff we're always so very particular about making sure that our documentation is neat and tidy. So when an error is made on a lab document, we like to white it out or use the whiteout tape or place a new entry on so that we can then place the new entry on top and it looks clean and neat. Unfortunately, this is not acceptable. Original entries must be visible. Correction tape or fluid cannot be used. And the corrected data must be clear along with the identity of the person making that change. So this slide demonstrates how a mistake on a document in the lab should be corrected. So in this example, I meant to indicate a refrigerator temperature of 2 instead of the 3. So to correct it, I draw a single line through the 3 and then indicate the 2 next to it along with my initials and date. This method ensures that if anyone ever needed to refer back to the erroneous data, they could, and they would also know who made the correction to the error and when the correction was made. Facilities located away from the main lab that hold a certificate of accreditation are required to have oversight documented when the medical director is not primarily positioned or regularly present at this site. In AP, this is necessary if you have offsite frozen section facilities. Medical directors are required to have documentation that shows that the offsite is visited and assessed on a predetermined basis. If staff are present at these sites, an assessment of staffing adequacy must be performed. If no staff are present, then the only thing they need to assess is the physical and environmental conditions, along with an assessment of just sort of that general oversight. These items might include things like, if there's PT there, or any quality control, safety, any quality monitoring as applicable. So this is an example of an offsite visit form where the medical director documents what they did during their visit to the offsite. This offsite visit form is for a frozen section facility where there is no staff, only the pathologist going to do the frozen. So the physical and environmental conditions assessment is seen at the top, in the top box, and is the only documentation that's absolutely required. Any other items are documented by the medical director at their discretion. And then just as a kind of a side comment, at our facilities, we do document this visit and oversight on a biannual basis. So the medical directors go out, they fill out this form, and then they will submit this to me documenting their assessment. Temperature monitoring is the next hot topic we will talk about today. Anything that has manufacturer's instructions mandating that a particular reagent and/or supply be kept at a certain temperature must have temperature monitored on a regular basis. This includes both temperature and humidity. So always make sure you are checking those manufacturer's instructions for temperature requirements. In the case where reagents and supplies that require temperature monitoring are stored in an area that are not staffed 7 days a week, it is imperative to have minimum and maximum thermometers so as to ensure that the temperature did not fall out of range when the staff was not present. Additionally, there must be documentation that the min-max temperatures are checked when staff return. When staff is out of range, when temperature is out of range, we must document corrective action. This corrective action must include what was done to accommodate the reagents and supplies until the situation was corrected. So for example, you can see at the bottom of the slide, we moved contents of the refrigerator to an alternative refrigerator, and then we marked that refrigerator as do not use, and we placed in a work order for maintenance. As described in the previous two slides, temperature is very important in certain cases, so you can understand why it would be necessary to check your thermometers for that expiration date. Make sure that you have disposed of any thermometer that has expired. Temperatures that are taken with an expired thermometer are obviously technically not valid. Quality feedback is essential for quality improvement in the histology and cytology laboratories. There must be documentation that a process is in place for pathologists to give feedback to the histology department for the technical work being performed. This could include anything from processing, including decals, your cutting and your bedding, to your H&E staining, IHC, special stains, the whole gamut. Documentation should be present demonstrating the assessment also of cytologic preparations in the same capacity. This is particularly important when you have cytology prep techs who perform all processing. Finally, documentation must exist for feedback to be given to the grossing personnel relevant to pathology assistants or other non-pathology lab personnel who might be performing gross activities. Because histology workflows are such that they flow through those different groups of people, it is important that each group does not work in a silo. Feedback should flow back and forth so that the improvement can be made if needed and issues are addressed. CAP inspections focus on this concept and are particularly interested in what was done as corrective action for feedback given. For the cytology prep area, we have a more manual method of documentation where we reflect our assessment on a staining QC sheet and on the Cytotech daily screening log. For histology, however, we do use the LIS to document our quality feedback. And believe it or not, our pathologists do actually document their quality feedback in the LIS. We print reports then on a regular basis so that we can assess that quality feedback. Probably one of the biggest and most consistent challenges I see in the histology and cytology areas, and really the lab in general, is the concept of saying what you do and doing what you say. And by this I mean to ensure that your policies and procedures are current and accurately reflect the current processes, policies, and procedures that are in place. And just as important, make sure staff know what your policies and procedures say and are aware of how things are supposed to be done. Many deficiencies arise in laboratories because inspectors peruse the policies and procedures and then go and see if that process is being followed in the lab, only to find out that it's not. So if you say in your policy that you take a particular monitor and you post it in the department and you discuss at your monthly meeting, then as an inspector, I should be able to go into the department and find that monitor posted and be able to review meeting minutes that show the departmental meeting discussion. This is a very simple example, but you get my point. So with that, I would like to conclude by saying that in all the years I have been inspecting and been inspected, I feel like I have learned so much. I find great value in the inspection process. In my opinion, I do feel like the more prepared I am for the inspection of my department, the less time I need to spend running around for the inspectors, and the more time I can spend appreciating the peer review of the way my department and I do things. I hope that you found this presentation worthwhile and valuable. If you have any questions, please feel free to contact me at my email address indicated in this last slide.